Welcome to the Fresh RN podcast. The information contained in this podcast is meant to supplement your existing knowledge and not replace it. Always refer to your state board of nursing, standards of care, and respective institutions' policies to guide your practice. All identifying patient details have been changed to protect their privacy and remain compliant with the Health Insurance Portability and Accountability Act of 1996. Thanks, nurses. Stay fresh. We're going to be great because we're on all these lovely little medications. But I mumble. Bumblebee tuna, because that's what I did wrong last time.
That's right. You know, they may just not like your face too much.
I do not take care of children. Oh, wait, now I have one. Thank you, Kieran. Protect my intellectual property.
Roll that beautiful bean footage. Ladies and gentlemen, we are.
You were going to say that. And if you weren't going to say it, I was going to say it. I love the way you say that, by the way. It sounds just like it.
I don't remember what the dog's name is.
Jake, obviously.
Jake. All right, guys, you ready?
Ready.
Welcome to the podcast. I am Katie Cleaver.
And I'm Melissa Stafford. Hey, guys. I'm Elizabeth Mills.
And we're back. And so excited.
We're back.
Yeah.
Very excited.
And we just realized we're recording this episode 1 year after we recorded the first episode, which is very exciting.
Yeah.
So today, though, we wanted to talk about how to deal with family members, but not just not upset ones, but just how to just deal with family members. Not that something horrible is going on, but how do you just talk to them in a critical care environment, on the floor? How do you facilitate that as a nurse? Because I was not prepared for that. You're focused so much on the patient and therapeutic communication and blah, blah, blah. But how do you deal with maybe not just their spouse, but all their kids and when nothing's going wrong? And one of the things that Melissa said that really stuck out to me was that you're a leader and you shouldn't have to wait to be spoken to when you walk into the room. And I really identified with that. So can you kind of elaborate on what she meant by that?
Well, I think that when you walk into the room, by acknowledging, you're looking at the patient, of course, but acknowledging the family automatically just gives you a sense of confidence. Hello, I'm Melissa. I'm going to be your loved one's nurse today. How are you doing? Even a simple good morning really can make a difference to the family, because now they don't feel like they are, I'm trying to think of the way to describe it, but basically that they're included and they don't have to kind of fight to be included.
Yeah. Because I feel like if you don't acknowledge them and already like kind of pull them in, it's almost like I feel like they'd be defensive. Yeah. I feel like I'd be a bother. Like, I'm not a part of this. All you care about is the patient. So if I ask questions, it's not like welcome, I guess.
Yeah.
I feel like how I would feel on that end of things.
Mm-hmm. I think that's right. I think that, if you don't feel included, then if I'm the family member, it puts me on the defensive. Mm-hmm. So then I'm starting to judge everything that you're doing. And, do you really know what you're doing? Are you an experienced nurse? Or, those
right.
kinds of things. And it starts kind of making the family automatically start thinking bad things instead of positive things. So, truly, it can be as simple as saying good morning to the family, and it makes a big difference.
Yeah, and I think one of the things we have to actively try to avoid and prevent is that us versus them mentality.
Yes.
And that if you walk in and just all you care about is the patient and the labs and this and the medications and stuff, if you're not like actively including them and walking in as a leader, like, hey, and you're confident, like, hi, I'm Katie. I'm going to be taking care of your loved one today. How are you doing? Or here's what's going to happen today or whatever. It kind of facilitates more of that team mentality. We're all on the same team with the patient at the center versus I'm here to do my job. Just don't bother me.
Yeah, absolutely. And I'm actually training somebody currently. And that was one of the things that stood out to her in orientation, that she realized that we really engage our family members a lot. And she goes, it adds another layer of stress for me because I don't know what to say. I don't know how to say it. She's new, she's learning. So it's difficult to sound confident when you're learning.
It is.
But, also being upfront with the fact that you're learning and that you're in training also helps. And, a lot of people will give you a lot more grace under those circumstances.
Mm-hmm. Mm-hmm.
And I think, just like Katie just said, they are part of our healthcare team. They are a wealth of knowledge, especially for our patients who can't speak for themselves. They're the ones providing the background, what's been going on with the patient, why they were brought in. So we have to present ourselves and engage with them in a way that says, you know, you're also helping us out, and you have to make them feel like they're part of the healthcare team.
Yeah, and valued.
And valued,
Yeah.
right? And they can be a great they can be a great help to us, especially, you know, with very simple things. And we can get into that in a little bit with talking about education. But if you can work well with your family, your patient's family, you know, it's a huge asset.
Yeah, and I think if you walk into the room and acknowledge and walk in with confidence, not like this cocky arrogance, but this like, I'm going to take charge of this situation and take it upon myself to make sure I introduce myself to you, not the other way around, because, you know, you're in my house and I need to take that initiative. It's my responsibility.
All I can think of is that song.
My house.
Welcome to my. I'm
Oh,
not singing it, but
Oh, we should have that playing when you go in and introduce yourself to your family. But you almost have to give them permission to be included. Like, it's okay. I want you to speak and I want you to be part of this world. And it's up to us as the nurses to pull them in.
yeah.
So that actually leads to the next thing I wanted to talk about was what you mentioned, education. So now that we've said hi to them in the morning or in the evening, now what do you say? And one of the things that we've all agreed is really important is proactive education throughout the shift. And what that means and what that looks like, and we can talk about what that practically looks like, but generally it's like, instead of, oh, we're going to go for an MRI now. Oh, I'm going to give this med, or you're waiting for them to ask questions and have that dictate things. Having it, you're the leader and you're taking the initiative to say, hey, this is what's going to happen today.
Yeah.
This is how, hey, we're going to have an MRI. I mean, I know things don't always go exactly to plan, but these patients and these family members are in a scary situation and they need some sort of routine or predictability. And by proactively educating can pull down that anxiety slightly, which makes it easier. And as opposed to being reactive. I don't know if you guys have had experience with that, or do you want to give an example of how you proactively educate at the beginning of a shift?
I mean, there's a whole slew of research being done right now on family engagement, and they're definitely coming up with more of a kind of a protocol on how to keep families included, reduce their anxiety and stress. And one of the things I like to do when I walk in and I meet my family is say, I kind of give them, you know, if they weren't with the patient overnight, just kind of give them a recap of the past, 12 hours or how they did overnight or what's been going on today. And then, I say, tentatively, this is what we have going on for the day. Things may change. We may do this. But to have them have a sense of some kind of preparedness, I think really helps them. And I give them a chance to say, I'm like, what kinds of questions do you have? What are your thoughts right now? What are your concerns? Because even though as nurses we may not be able to give, exact results of things or give definite answers on, prognosis or what it looks like, we can kind of allow them to, I guess we can kind of give them an idea of what things are looking like and have them we can help address some things that they're thinking about or issues.
And I like how you said that. What kinds of questions do you have versus do you have any questions? You want to have that open-ended dialogue that gives them a chance. And almost if you say, what questions do you have? It's almost like, please ask me a question as opposed to a yes or no answer as you're halfway walking out the door. Like spending that time at the beginning of the shift, roughly, even if it's an overnight shift, hey, the goal tonight is to sleep. I think we both need to wake them as least as possible. So let's cluster the time and working together as a team, and then continually asking, what kind of questions do you have? What concerns do you have? Is there any information that you're missing or that didn't make sense? Let me process that with you. And that can just make such a difference. I mean, if you picture those two different ways of attacking a day with a patient and their family, one is just waiting for the family, not acknowledging them and just waiting for them to tell you when they have needs versus, hey, I'm I'm putting out the effort. I'm putting my hand out to shake your hand, to say, hi, I'm going to take care of your loved one. I'm going to do a good job. I'm going to do this. I'm going to tell you what's going to go on. We're going to do this together. Like, I was just like, that's such a big difference. And it's so small, but it can change things and make them trust you more.
Yeah.
Make the
That's what it's
shift.
all about.
Oh, yeah. Because if they don't trust you, they are going to be like,
They'll be at the desk all the time.
Oh, yeah.
They'll be looking for you.
The call bell will be
Going
going off every 5 seconds.
yeah. And actually, that one thing that Elizabeth had mentioned about proactively educating on, things like alarms,
Yeah.
equipment, and there's a really, like, 'cause especially in the ICU setting, there's a lot of alarms.
Yes.
There's always something
Yes.
beeping.
And to the family, and this is our house. This is our everyday. This is our. That goes along with what you were saying. Welcome to my house. But a lot, like as you guys know, a lot of the alarms are non-actionable or not a huge deal. But to that family member who's never been in our house and doesn't know our alarms and our noises, everything is terrifying, especially because their loved one is hurt or sick or whatever. So their anxiety level's up. They don't know what's going on. So any noise they're going to make a big deal about. But Elizabeth had a really great way that I thought, do you want to share about how to educate about that?
So you can kind of educate our families about the alarms and making comparisons to stuff that we would hear in your house. So, certain alarms. Oh, that's me telling. That's like you at your house hearing the dryer go off. We have to have these alarms in place, but not every alarm means you need to come running. And it's so important, I think, kind of right off the bat when the patient first arrives or when you first are meeting family, to kind of set that off bat. Like if my patient's on a ventilator, I tell the families when the patient starts coughing or, takes a deep breath, these ventilators alarm, and they're very loud and they're very scary. But it doesn't necessarily mean something bad is going on.
Mm-hmm.
When a blood pressure is a little too high or and makes, a beep or whatever, or if there's, a PVC on the EKG, the alarm goes off. I tell them, that means we, it's not a big deal. It's just telling me something that something has gone off and I need to address it. Maybe not right away. And alarm fatigue, that's a whole nother situation, but alarm fatigue is a big thing right now, and especially in critical care. And, we have to have these alarms in place. They have to be loud. We have to, especially certain like crisis alarms and stuff, we have to be able to hear them all over the unit. So unfortunately, these are things that the families are going to hear. So it's important to kind of try to establish some kind of sense making comparison, I guess.
Yeah.
I tell them, I literally will say the words, there are a lot of sounds in the ICU, and they all mean something different. But ultimately, and this is true kind of even just in patient care, I'll tell them, don't worry. You can worry when you see me getting worried.
Mm-hmm.
And just kind of give that as a guideline, because, if they're panicked over everything, and I understand that because these alarms are scary. They're not used to hearing them. They're not used to seeing their loved one in the hospital. But it's really important that they understand that, like you said, we have a lot of alarms that tell us different things, and we know which ones we have to get up and run for. So just be patient with us. You can always ask a question, but just, we'll let you know when things are getting more concerning, because we'll be very upfront about that.
Mm-hmm. Yeah, I've had experiences where, like, a lot of us have had patients whose loved ones are former nurses or current nurses, and sometimes they're, people just can be kind of scrutinizing and ask a lot of questions, and I think that's an important point, or important time for that nurse, that bedside nurse, to not shy away from that and not be intimidated or frustrated by that, because half the time, I would say most of the time, they don't expect you to have this crazy nursing knowledge, but just to be able to say, hey, provide this reassurance that, yeah, I do know what I'm doing. We're okay. And I've got a lot of support staff around as well. Your loved one's in good hands. I remember one time I had a patient whose wife was a former nurse. Of course, it was like 30 years ago that she was practicing, but was pointing
I
out.
think I was working
you-
with you this day.
You absolutely were. And we were frustrated because it was every little thing, and the things that she was pointing out just really didn't make sense. But she hasn't been a nurse or she hasn't worked at the bedside for 30 years. Her husband has had this major traumatic event. So, and she's just, and you could tell was just a ball of anxiety. And it was just like I just needed to prove myself a little bit to her. And I didn't say anything that a nursing student didn't know. But it was like, she just needed to hear me kind of be confident, I think. And that kind of had her unclench. And just being able to, like, you don't have to say something crazy in this crazy disease process and explain something super eloquently. It's just kind of having that confidence and reassurance. People just need to see that, I think.
And I actually would like to make another comment about loved ones who work in healthcare. So whether they be nurses or whatever, they may not work in that area of specialty. So, me being in the neuro ICU is way different than me being a cardiac nurse or a labor and delivery nurse or, those kinds of things. So they may have somewhat of a medical background, but that doesn't mean that they know everything that's going on right now. And acknowledging their background is important, but treating them just like you would treat them as any other family member. And sometimes I'll say, I don't mean to sound insulting. That's not my case. I just want to make sure that I'm explaining everything clearly, both for you and whoever else happens to be in the room who's not medical. And then let them guide the conversation. So if they have a good understanding of what you're saying, then they will ask more specific questions.
Yes.
And that's okay.
That is such a good point. I didn't even think about that. But because I've done that before where someone says they have this medical background. So I just assume they have this certain level of understanding. And then later on, it's like they're asking questions where it's like, oh, wait, they don't have that. And that's a bad thing.
Right.
But I should not assume that. Just because they say they have a medical background, I still need to talk to them in that, like, maybe say, forgive me for, I just want to make sure I educate on whatever. I don't know. Forgive me. I don't want to be insulting, but I'm just going to explain this like I would to someone who didn't, because I just want to make sure, whatever. Like, I think that's so important because, too, I think a little bit in the culture of the medical community is, oh, I know, I got it, or I understand, but sometimes you don't.
Yeah.
And if there's a time to really ask questions and be okay with asking even the silly questions, it's when your loved one is sick.
Yeah.
And
when I was in the hospital having my son, I did not tell a single person that I was a nurse. And I avoid that because, yes, I'm a nurse. Yes, I'm a critical care nurse. But I don't know nothing about birth and no babies.
I did that too. Well, actually, the nurse that delivered my daughter she knew me, and because it was at the same hospital I worked, and I just knew her already, so she knew I was a nurse. But it was like, yeah, with that postpartum period, I know nothing about children. Nothing.
Right.
I do not take care of children. Oh, wait, now I have one. Talk to me like I'm an idiot that has no idea how to take care of a child. Not that you're an idiot if you don't know. Don't take that to mean that. But, like, talk to me on the most basic level ever, because I do not. Just because I'm a nurse doesn't mean I get this.
And you functioned. Your functioning as a mom is way different than functioning as a nurse.
Yes.
Like, so
Yeah.
bear that in mind as you're talking to loved ones who are in the medical field. And it doesn't matter if they're nurses or physicians or what have you. A dentist is not going to understand necessarily what's going on with the patient who has a subarachnoid hemorrhage.
Right.
They certainly will understand some of the same medications, and if we're using, anesthetics and things like that, but it doesn't mean that they're going to understand everything that's going on. So just treat them like you would any other family member, and then let them guide the conversation. If they want more detailed information, they'll ask for it. And that, and be confident in that. And if you don't, then you tell them the truth. I'm not really sure how to respond to that, but let me find out for you.
Yes.
And that's okay too.
And that is okay, because at the end of the day, it's not about your ego. It's about what's best for the patient and ensuring those family members know what's going on. So if you don't know something, don't fake it. Just
don't
It's
fake
okay
it.
to say I don't know.
It's okay to
Yeah.
say
It's
I
okay
don't
to say,
know.
I'm not sure. I'm working to try to find it out.
Exactly. You want to say it confidently. Hey, you know what? I'm not sure, but I'm going to find out that answer for you, as opposed to, well, I don't know. Like, that is so important to do that, or to be confident and be honest with what you don't know, because they need to know the answers to their questions. And it's not about you proving how much you know, and it's not about your ego. It's about the patient.
And I find that, working with family members who do work in healthcare, or regardless, they're in a vulnerable position, and they feel like they have no sense of control.
Yes.
So you need to try to allow them to have a sense of control over something. And that's where educating them about what they, a lot of times family members say, can I hold their hand? I'm like,
Yeah.
absolutely. I was like, it's comforting for that family member to know that you're there.
Mm-hmm.
Or, it's okay to, give them a kiss, or it's okay, and allow them certain things to do. If it's
Range of motion, is
range of motion, rubbing lotion on their hands and their feet, or even like suctioning their mouths. I mean, and that gives them a sense of, I have some control over this situation,
And I'm contributing.
Yeah, I'm
And you're
participating
contributing.
in their care.
Because I do find that, like people who feel like they know a lot about, I don't know, or they're trying to find the answers themselves in their head. So that's why sometimes they're like, what is this, they spout out stuff like they know what's going on, when really they really don't. I mean, in a I don't know, weird sense. That might
Well,
be.
your experience in the provider role is way different than your experience in the family member
Yeah.
role.
Right.
And it's really hard to rectify that sometimes.
Yeah.
Yeah, because people are so used to their provider or their whatever role that fitting into that family member role is really awkward and uncomfortable,
Yeah.
and you don't even know how to act, so you just revert to what you know.
Right.
When it's like, hey, man, you're going through whatever.
Yeah.
You want to answer the questions and support them and give them things to do so that they feel included in that. And yeah, it's really, and so needless to say, they're going through a lot of challenging things, and they don't need the nurse to be there to just come in and be kind of a robot and take care of the tasks and not acknowledge them, but really kind of pull them in. And it's going to be messy and sloppy, and it's not going to look perfect, but got to be willing and confident, I think, within it.
Yeah. And can I say one more thing about proactive education?
Oh, yeah.
It just being that if you know something is going to happen later on, then,
Yeah.
Let the family know.
Yep.
And I don't just mean procedures. I mean, in my case, and I'm sorry for using so many neuro references, but I've worked there for a really long time.
Yeah.
Sorry, not
But-
sorry.
Yeah.
But I have a patient who comes in with a hemorrhage or an ischemic stroke. I know in 3 days their edema is going to be worse.
Yeah.
Mhm.
So explaining to the family that over the next few days, we may see some decline, and we'll be monitoring that. We might have to do something to intervene. But I want you to know that it's expected and it's something that we're anticipating so
Yep.
that we can address
Absolutely.
it promptly, so that they're not terrified by the fact that their loved one is getting worse. I mean, they are, but that they already know we're expecting that, and that that we as providers are being proactive for that.
And I think that shows that you're a competent, experienced
Mhm.
nurse.
Mm-hmm.
I mean, that you are preparing them for, this is what we could see. Maybe we won't, but just like subarachnoid hemorrhage and vasospasms. I mean, it's this is going to be what we're going to be looking at for the next 72 hours up to 7 days, whatever. But
Yeah, and like kind of like with a cardiac patient, if they're an open heart or if they're a cabbage, and okay, 30% of you guys are going to flip into AFib. Probably good to mention that.
Yeah.
Hey, if this happens in the post-operative period, we know how to deal with it. We need to address it quickly, but it's not something that that can be really scary to all of a sudden they hear the monitor going crazy and we're in there doing vitals and then starting a cortisone drip or doing a synchronized cardioversion. Like, that can be really scary, but just to know that, hey, we've done this before, we know what's going on, and we know a certain percentage of patients experience this. Or if you've got someone that had a FemPop or some sort of vascular surgery and they're going to be on a heparin drip and it's going to take a little while to bridge to Coumadin, and you anticipate it taking like those, or the post-op pain patient.
Yeah,
And
that's
hey,
exactly.
right after surgery, we're going to be great because we're on all these lovely little medications. But
anesthesia.
yeah, but
so
then
on
a
board.
few days later, it's going to hurt like hell.
Yep.
And that's not to say things are getting worse. It's actually the expected progression. Yeah, and so that stuff comes with time, but the more you can educate your families about it, the better. And there is one other thing I did want to kind of talk about, because we do want to talk about how it's important to pull them in, but there's also a point where there's boundaries too, because that fine line between pulling patients' families in to be super included in everything can quickly cross over into like them dictating medical decisions that are, medical care in a way that's not appropriate from
Right.
not the provider. Classic example is like the patients or the family member saying they need antibiotics, give them antibiotics when it's not appropriate or whatever. So can you guys talk a little bit about boundary setting, how important that is, or what that practically looks like?
Well, I actually had an experience with it this week where I had a family member who kept silencing my alarms.
Whoa!
Everything from the heart monitor to the IV beeping. And I don't know how they got the secret button, found it, whatever. They may have just been watching us. But I was down the hall, and in this particular case, the IV pump kept beeping, but then it would go off. So I thought, well, somebody's in there. Somebody's in there fixing it. I thought another nurse was in there.
Yeah.
So it started going off again, and finally, the family member came looking for me, and she was like, "This IV pump has been going off for the last 5 minutes." And I was like, "Oh, I kept hearing it go. Like I kept hearing it silenced." I said, "I thought somebody was in there." She goes, "No, it was me." And I was like, and the IV was occluded, but in this particular situation, I went in and I was like, oh, that, you know, when I hear it silenced, I'm thinking somebody's in there.
Mm-hmm.
And I was like, you know, I know it's an annoying sound, but if you let it ring a little bit longer, it's such an annoying sound. Someone's coming in.
Like that's definitely included in the game of Clue. Like it was the family member in in the hospital room with the mute button.
And she was very nice. Like, and I said it. I was like, I get it. I was like, that thing is annoying as all get out. But I said, you know, it like I would have come running quicker had it kept going off. But it sounded like somebody was in the room. And I was literally all the way down the hall. Like this was room whatever, 15, and I was down in room 7.
Yeah.
So it's like, you know, and I mean, I'm telling you, and we as nurses, we're attuned to we know these alarms.
Oh,
So
yeah.
I can tell you when this beep goes off, the IV's doing this. And when this beep goes off, the IV's doing this. And then another thing with silencing the telemetry alarms.
Oh, wow.
And in a way, you do have to be firm. Because with that's a safety, that's a big safety issue. And so it was another family member this week, and I was like, I know you don't want to hear these noises, but I can't allow you to silence this alarm, because when you hit silence, it silences it for 60 seconds. So if there's a drop in oxygenation or a drastic change in heart rate or blood pressure, it's not going to go off again. So I need to know. And he understood. He's like, I'm sorry. But I was like, it really is a safety issue. And I think in good practice, if we can be good nurses and healthcare professionals in addressing our alarms that need acknowledging right away, or setting alarms to where they're not going off all the time, family members aren't going to want to do that. But I said, you know, but we have to have alarms in place. There's no way we can take these alarms off.
I think too, and that goes back to that proactive education too.
Yeah.
One of the things that I found is a common misconception, which I mentioned in that Admit One book that I wrote, is I think family members think that the IV pump is like connected internally to like the front desk, so that if it's in the same, and I know the telemetry monitor is, but I think they think it's connected in a way that's different than it is. So they think that even if an alarm goes off, that we somehow get like a message or like a push notification or something.
Yeah, that'd be nice. Actually.
That would be really, that would be incredibly convenient. But that's not how that works.
I've just stumbled upon the next $1 million idea.
Copyright.
I was going to say
we're gonna
copyright.
edit that.
Thank you, Kieran. Protect my intellectual property. But I think that goes back. Like, I'm sure that those, and I'm glad you said that they were both receptive. They don't want their loved one to hear the alarm, and they probably assume that we get the message somehow.
Especially in the middle of the night.
Yes. Yeah. So it's like educating that, you know, I don't know, being empowered to walk in and but not use that as an excuse to do a power trip or to do this isn't how this is going to go. But hey, I just want to let you know, like, this is a safety thing, and I know it's annoying and I know it's frustrating, but this is kind of the name of the game and how it's got to be.
Yeah, and I mean, you don't always have to have happy, joy with your family members.
Right.
I mean, as long as it's all about the delivery and it's empathizing with them, saying, you know what, I know you're upset. I get it. Like I get, why you don't, you're overwhelmed with this place. And
With my house.
with my house. I mean, I get overwhelmed with my house too. I'm ready to leave my house sometimes. I need to go on a vacation. But but it's about collaborating and working with them.
Mhm.
And there's going to be some days, they may just not like your face too much, but
But at the end of the day, it's for the patient. And I
It is
love
for
that
the
you said you
patient.
don't have to be happy, happy, joy, joy. Because sometimes you do have to have those business, like, this isn't personal. This is about the safety of the patient. Or this isn't personal, but there are too many people in the room. I know
Yes.
we got to have just a couple in the room right now, or next to kin, or whoever it is, because right now it's impeding my ability to be able to take care of the patient. And then if you say that in a calm, respectful, business-like tone, and it's not personal, or, hey, can you do me a favor? It's just, there's a lot of people in here. It's like, no. Hey guys, we're only gonna have 2 people in the room right now because there's a lot going on, and we just gotta
I
do
have
that.
to be able to get over here. Yeah.
Yeah,
Yeah.
we need to take turns, or one of the things I think we've done every shift is, hey, we're gonna do a bath right now. If you guys, this would be a great time for you guys to go get some coffee. Give me about 20 minutes. Like those kinds of things, or
Yeah. I mean, it's challenging too, because
It is challenging.
I find that if I need to get to the patient and they're in the way, it's like in my head, I'm thinking, could you please just stay out of my way for just 10 minutes
Yeah.
and let me do what I need to do?
Yeah,
But
yeah.
I can't just say that.
Yeah.
Yeah.
But it is, you do have to learn how to be firm but respectful of
Right.
families. I know that you want to stand there and participate in this neuro assessment, but I need to see what they can do with me.
Mm-hmm.
I need to see how they respond to me, and I need to see in what kind of stimulation it takes to get them to wake up and do things.
Mhm.
So if you can give me 10 minutes and you stand right there and you can watch, but let me see what they do.
Don't cheat for them.
I actually make a joke about that a lot.
Yeah, no cheating allowed.
Yeah.
Don't cheat.
So here's a question for you. Going back to what you said earlier about being open and honest with the patients and the family members about what's going on, and admitting that it's okay not to know certain things. Are there times or what's the line of what you're not sharing, and when is it helpful not to share? Or obviously not the mute button for the alarms, but like what else is in that range where maybe that's not what you should be
Sharing.
yeah
I mean, there's certain things that as a nurse you really don't want to share, like that's out of your scope, like
Specific test results, like
Yeah.
imaging studies.
like common in
It's-
the neuro ICU is that
it's
CT scan,
CT
that
scan,
follow-up
MRI.
CT.
And I'll sometimes say, you know what, I was like, I don't have exact report yet. If it was something drastically different or drastically worse, I would know right away, and we'd be getting the doctor in here to let you know. And sometimes I say no news is good news.
Yeah, that's
And
a
the
good
physician can go over the specific results with you, because we're not trained to we're not experts in knowing what some of this stuff means, but I do say that if something bad was, or if it was a really, for example, a hemorrhage, if the hemorrhage was much worse, I was like, you'll be notified right away.
one. Mm-hmm.
Yeah, and I sometimes say things like, for the scans that are just like routine scans, I go based on the patient.
Yeah.
I don't know what the results are, but the patient's doing great. So
Yeah.
I think that's a good thing.
And
Yeah.
that
You know?
further instills that trust.
Yeah.
Mhm.
I do think one thing, though, that I don't share is when the doctor's going to be by.
Oh,
'Cause
yeah.
I don't know.
Yeah.
And as soon as you tell that family member that really wants to talk to the doctor what time they're going to be by and they're not there, you've disappointed them.
Yep.
And truly, I don't know who knows when their doctor is going to be by, because so many variables are in place or that can happen. So I that can prevent them from showing up on air quote time.
If you have like a unit where you have set interdisciplinary rounds,
Oh,
I
yeah.
know we do in our unit now. I say we start rounds around 9:30 in the morning, and we go through the whole unit. So it may be an hour before we get to you, but if you want to kind of get kind of an update on what the plan is, sit and listen. And sometimes it's interesting because I love for families to listen in on rounds because it helps answer some of their questions, but then they also like to participate a lot. And they start, and there's a very symptomatic process with our rounding, kind of what's going on, and they sometimes they like to jump in all the time. But nonetheless, that helps get the family sort of prepared for when the doctor's going to come by. Now, if it's other consult physicians like cardiology or infectious disease or whatever, there's no way to predict what time they come by, so I don't give them any expectation specific times.
And I think one way I've started to communicate that is, man, I wish I knew. If you find out, you tell me.
Oh, yeah.
And then
said
it's
that
like,
too.
okay, we truly are on the same team because we don't know. It'd be great if we knew when they came by. That'd make my life easier.
I know, and I tell the families too, if they come in and I'm not here, you hit the call button.
Yes.
Yeah,
Yes.
no, yeah, yep, exactly. Because we need to listen to what they have to say too.
Yes.
They don't get to sneak in and sneak
no.
out.
They have to talk to me, whether or not they want to. Yeah, Melissa, you said something that made me think of something. Now I can't remember it, but it was important.
So descriptive.
I've said a lot of things.
You
There's
know,
no telling.
one important thing, and this is kind of my soapbox this past year, but having families, and some nurses don't like this, but I really do like encouraging family members, especially in the ICU, to keep a log, to keep a journal, to write things down, write questions down as they think of them. That gives them something to do. Sometimes they'll like go sit in the chair and start writing things down when I'm in the room, and I'm like, this is metoprolol and this is aspirin, and they're writing it down. So then I can be at the bedside, like getting my stuff done.
Yeah, actually, I wholeheartedly endorse that so much that, that Admit One book that I wrote, the back of it is blank and with leading questions and places to take notes. I think there's a balance between, what was that last of blood pressure, and writing every 15-minute blood pressure down. That, there's a balance between kind of taking notes, but then going crazy with it and getting obsessed with it. I think encouraging that is helpful, because one of the things I've said too is also write down questions as you think of them, and
So you'll
answers
forget
as
them.
you receive them.
Yeah.
So that you can continue to go over it, because putting that clinical picture together, especially, I know to go back to neuro, but patients that have a neurological injury, that's a very complex situation. That's, hard for, the nurse who's floating over there to understand, let alone the patient or family member who has no medical background.
Yeah, I definitely encourage them to write down questions, because you'll think of 10 questions as soon as the doctor walks out of the room.
Yes.
Oh, yeah.
Yes.
And
And ask the nurse.
I will say sometimes I'm like, the doctor was just in here. That question.
And I don't know the answer.
Am I not intimidating as well? Do you not see my face? I'm just kidding. I'm just kidding.
Don't
I'm totally
intimidate your
kidding.
families. All right. Do we have anything else? I know we did want to briefly mention next of kin and how important that is, especially if you have a neurologically compromised or an unconscious patient who you can talk to. One of the things that's important to establish when you see a patient family member or loved one in the room is to never assume who they are, but in a very non-judgmental, business-like tone. Hey, how do you know Mr. Smith? How are you related to Mr. Smith or whatever, as opposed to being like, who are you? Or just assuming that because they're there, they get privy information. Because there's also that line too. We have all had patients who have had loved ones in the room that were not supposed to be there, that the patient would not have wanted them to have information, and we find out later. And I've also made an idiot out of myself, assuming that a loved one was who they were, and they weren't. I called a patient's wife his mother once. So y'all don't do that. Do not assume that just because someone is near them, and an older woman, that's their mom, because it could be their wife, and you could look
Or
ridiculous.
their
be
girlfriend.
Yeah, right.
Oh,
You have an 80-year-old patient and it's a 40-year-old woman, and you're like, "Oh, are you his daughter?"
Yeah, and no. Yeah, so so always with that business-like tone. But we also want you to know how important it is to establish who those people are. You can't just assume that because they're here in the hospital, they're privy to information. Just because they say they're their sister, maybe that's their church sister or their friend who's been like a sister.
Well, or they say I'm the patient's mom, and it's not like we check a birth certificate. You know,
Right.
so there's a certain amount of responsibility of the visitor, to be honest about that.
Yes.
But I also want to mention too about, healthcare power of attorney. Especially when you're talking about consents for things, because if they have a healthcare power of attorney, that person is going to take precedence over
Anyone else?
anyone else. but the guidelines will be different based on the state that you're in, the facility that you're in. So
Yeah.
there's probably a policy somewhere that literally spells out who to go to and what order for consents and things.
Yeah, and case management and social work are a great resource. We've had times where we've had a patient who is incapacitated, and we're trying to make end of life decision kind of things. There's not a spouse, or the spouse is divorced or separated for a long period of time. Are they, is the divorce final, and how many kids do they have? Okay, well, it goes to the kids, but there's 7 kids and they don't talk to each other. Like, those are very convoluted, very crazy situations.
Yeah.
So you leverage your resources, because it's not up to you to navigate that yourself and make those decisions by yourself and say, okay, you get to decide now, this is what the family wants to do. Like, no, you pull in that case manager to navigate that murky water, because that can be a little challenging.
Yeah. I mean, I think in the end, it's just important to have a very good understanding of how you lead in with the family is going to be determine kind of how your shift's going to go.
Mm-hmm.
So if you essentially isolate the family and don't engage them in any way, they're going to become your worst nightmare.
Yeah.
Mhm.
But if you control it and introduce yourself, speak to them all the time, have that kind of open atmosphere, attitude, then they'll be your best friend and your best advocate, honestly.
Absolutely. Anyone have anything else to add on working with family
And
members?
just because your nurse has an intent or a strong resting grumpy face does not mean that they're mean people. That's all I got to say.
they're thinking.
They're thinking.
Word.
They've got a lot on their mind.
I
They're
think
in the moment.
Elizabeth might be speaking for herself.
Are you being defensive now? What's
Yes.
happening?
I don't know. The past year, my resting grumpy face has gotten profoundly worse.
Apparently mine has too. I had a patient that literally said one day, and it's first thing in the morning, y'all, I'm not a morning person. And he says, "Can I ask you a question?" I was like, "Of course." He goes, "Are you mad at me?" And I was like, "Oh my gosh, I have to
No.
fix my resting grumpy face." I had no idea. No, I'm like, "No, not
He
at
felt
all."
empowered to ask you that, though,
He
so that's
did.
good.
But you know what? We were best friends for the rest of the day, though. So, but I
Aw.
did. I was like, "Oh."
All right. Well, thank you guys for listening. Check out freshrn.com/podcast for the show notes to this episode, and show notes and links to all our other episodes. So thank you guys so much for listening, and stay fresh.
Damn girl, better hit the floor. All the other fellas better run for the door. Stop, drop, and roll with me. I got the heat.